First, mechanisms of injury. Then the ER workup, spleen and liver, bowel and pancreas, damage control, and we'll wrap up with compartment syndrome and complications.
Starting off with Section 1, Mechanisms of Injury. This is all about predicting the damage before seeing the organ.
Now, what's really interesting about this slide is how understanding the exact physics of an impact predicts exactly which organ took the hit. Just look at the distinct injury patterns here. On the left side, with blunt abdominal trauma, the spleen is the undisputed most common victim, followed by the liver and then the small intestine. Think about it. If a patient isn't wearing a seatbelt and suddenly decelerates, their mobile abdominal organs keep flying forward while the fixed organs stay put. This creates a massive shearing force directly at the junction of the fixed and mobile segments, literally tearing the JJ flexure. On the flip side, if they are wearing a seatbelt, the mesentery of the bowel gets brutally compressed against the vertebral column. Now shift your attention to the right side. In penetrating trauma, the liver takes the top spot. But if we're talking specifically about a gunshot wound, the whole game changes. The trajectory of a bullet makes the small intestine the most commonly injured organ.
Moving right along to Section 2, the initial workup. Navigating the ER decision tree. Listen, when a trauma patient rolls through those doors, decision-making has to be lightning fast. If you've got a hemodynamically unstable patient with peritonitis or, say, a knife is still literally lodged in their abdomen, you skip the CT scans. And you absolutely do not pull that knife out in the ER because it might be the only thing tamponating a major vessel bleed. You rush them straight to the operating room. But for our other unstable patients, we rely heavily on one specific tool.
And that tool is the FAST exam. It stands for Focused Assessment Sonogram in Trauma. It's essentially a rapid emergency room ultrasound, and it's the absolute first investigation you do for a hemodynamically unstable patient. What are we looking for? We're scanning specifically for free fluid, which in a trauma context is blood. On your ultrasound screen, this blood is going to show up as hypoechoic, or black areas. It's incredibly fast to do, but remember, it's highly operator-dependent, meaning it's only as good as the doc holding the probe, and it notoriously misses retroperitoneal injuries.
Remember this for the exam, and more importantly, for the trauma bay. We place the ultrasound probe in a very strict, rapid-fire four-step order. 1. The epigastrum or subxiphoid space to immediately rule out cardiac tamponade. 2. The right upper quadrant to spot any blood pooling around the liver. 3. The left upper quadrant to check around the spleen. And 4. The suprapubic area to look for blood dripping down and collecting deep in the pelvis.
But here's the catch, and it's a critical limitation of the FAST exam: 100. You need at least 100 cc's of free fluid actively pooling in the abdomen to trigger a positive FAST exam. Anything less than that, the ultrasound might look completely clear, even though the patient is actively bleeding inside.
All right, Section 3, Spleen and Liver Injuries. Grading the damage.
Let's start with the spleen. If you see fractures on the 9th to 11th ribs on the left side, or if your patient is complaining of left shoulder pain when their legs are elevated, that's known as Kerr's sign, by the way, your alarm bells should be screaming splenic injury. So here's how we actually grade that damage. Take a look at grades 1 through 3. They're totally identical for both the spleen and the liver, basically scaling up from minor 1 centimeter lacerations to larger hematomas. Now, patients with grades 1 to 3 are usually stable, so we manage them conservatively with serial 24-hour CT scans. But, and this is a major recent guideline shift, if you see a contrast blush on that CT scan, meaning there's active arterial bleeding, you don't just sit back and watch, you immediately proceed to angioembolization. Now, notice grades 4, 5, and 6. This is where the organs totally diverge. A grade 5 spleen, it's completely shattered. The liver, on the other hand, goes all the way up to a grade 6, which is a catastrophic hepatic avulsion. Unstable patients with these high-grade injuries are rushed straight to surgery.
Once you open the abdomen and find a massive liver hemorrhage staring back at you, you rely on the 4 P's of trauma surgery to stop that bleeding. First up, push, literally just applying bimanual compression. Second, the Pringle maneuver. This one is absolutely crucial. You reach right into the foramen of Winslow and clamp the hepatic pedicle. If the bleeding stops, boom, you know the source is the hepatic artery or portal vein. If it keeps bleeding, you're dealing with the hepatic veins. Third, plug, using a balloon tube. And fourth, pack. This is where you surgically cut the liver's triangular ligaments to drop it away from the diaphragm, and you just aggressively pack surgical sponges above and below it.
Moving down, we hit Section 4, Bowel and Pancreas Trauma, Ischemia and Surgical Fixes.
Getting deeper into the abdomen, let's talk about the mesentery. That's the vital tissue supplying blood to your intestines. Remember earlier we mentioned how a seatbelt can literally crush the mesentery?
And this brilliantly illustrates why the physical geometry of that tear dictates life or death for the bowel. Over on the left, we've got a longitudinal tear. Because the tear runs parallel to the blood vessels, the adjacent branches simply take over the work. The blood supply is maintained, the bowel doesn't die, and the surgeon just goes in for a simple repair. But look at the right side. A transverse tear cuts right across that vascular arcade. The blood supply is entirely severed. That segment of the bowel immediately undergoes ischemia and dies. The only fix here is a full resection, cutting out the dead bowel entirely, and an anastomosis to stitch the healthy ends back together.
Now, for the other surrounding organs, our surgical fixes are highly specific. A duodenal perforation requires a Graham's patch, which is literally plugging the hole with a piece of the patient's own omentum. For the pancreas, your absolute ultimate prognostic factor is the main pancreatic duct. If it's disrupted to the left of the superior mesenteric vessels, you perform a distal pancreatectomy. If it's disrupted to the right, you do a Bedges procedure to preserve the duodenum, and for a colon or rectal perforation in an emergency setting, we do a Hartmann's procedure. We bring the proximal end out as a colostomy and staple the distal end shut, basically dealing with it later, assuming the patient survives the night.
Which brings us to Section 5, damage control surgery, knowing exactly when to stop.
This is perhaps the single most profound concept in modern trauma surgery. Sometimes trying to fix everything at once will actually kill your patient. You absolutely must memorize this, the terrible triad of trauma: hypothermia, acidosis, and coagulopathy. When a bleeding patient gets too cold, their blood becomes acidic, and their clotting factors completely fail. They'll start bleeding out from literally every surface. Hitting these physiological red lines is the absolute, non-negotiable indication to instantly retreat, pack the abdomen, and initiate damage control surgery.
Let's move to the timeline and see how this builds across a patient's survival journey. Phase 0 is just identifying this critical patient in the ER. Phase 1 is a lightning-fast trip to the operating room. Now, the goal here is not to make the anatomy look pretty. The only goals are to stop the bleeding and stop the spilling of bowel contents. We temporarily close the abdomen, honestly often just using a specialized plastic bag, and rush them to Phase 2, the ICU. Here, over the next 24 to 48 hours, the intensive care team works like crazy to aggressively warm the patient, give blood, and correct that terrible triad. Only after their physiology is finally fixed do we enter Phase 3, going back into the OR to definitively reconstruct their anatomy.
Section 6, Abdominal Compartment Syndrome and Complications, the Post-Operative Threats.
Because getting out of the OR alive, that's really only half the battle. Down in the ICU, the trauma journey continues, and new silent threats begin to emerge. One of the deadliest is abdominal compartment syndrome. If the bowels swell up from all that massive fluid resuscitation, the pressure inside the belly skyrockets. It literally crushes the lungs, the kidneys, and stops the heart's venous return. We measure this indirectly by hooking a pressure transducer up to the patient's urinary catheter. If that bladder pressure sustains a value of greater than 20 millimeters of mercury alongside some new organ dysfunction, your diagnosis is confirmed. The treatment? No way around it. You have to immediately open the abdomen back up in a decompressive laparotomy just to release the pressure.
We also have to be hyper-vigilant for organ-specific complications, particularly after a splenectomy. Lean in closely for this one, because here is a massive clinical pearl. If your post-splenectomy patient spikes a fever on day 2 or 3, it is almost always atelectases, a collapse of the left lower lung. It's not a systemic infection. The dreaded infection is OPSI, opportunistic post-splenectomy infection, and it's driven by encapsulated bacteria like pneumococcus. This is exactly why patients must receive targeted vaccines either 2 weeks before an elective surgery or as soon as possible after an emergency trauma removal. Also, keep a really close eye on your surgical drains. If that fluid is turbid and rich in amylase, you've probably inadvertently clipped the tail of the pancreas while taking out the spleen. And hematologically, you should expect to see Howell Jolly bodies on a blood smear as a permanent marker that the spleen is gone for good.
So, what does this all mean? It leaves us with this final, truly profound question to consider. In trauma surgery, when does doing less in the operating room actually result in saving more lives? As you'll see with damage control surgery, mastering trauma isn't just about knowing how to stitch or resect or operate flawlessly. It's about understanding the brutal physics of the injury. It's about respecting the unyielding physiological limits of the human body. And honestly, it's about having the clinical wisdom to know exactly when to stop, step back, and resuscitate.